Hey guys, Melanie Grant here. This is our 2060 HIT course on reimbursement methodologies and our review of Chapter 4, Reimbursement Methodologies in Healthcare. I'm going to go ahead and share my screen, and we'll be reviewing some of the information on our PowerPoint, as well as some of the exercises that are in our book, and just kind of clarifying what some of these definitions truly mean. So bear with me as we get started. Okay, so reimbursement methodologies, of course. We'll go ahead and start on our third slide, but as you know, you can see our learning objectives in the book and in the PowerPoint. The first thing that's really important, though, in this chapter is talking about the different types of reimbursement, or in other words, payments. Just as there are with Latin and medical terminology, remember that most of our English language also has Latin roots. And so when you see these terms, you have perspective in both of them. So different types of perspectives, spectives rather, both retrospective and prospective, meaning looking behind and looking forward, or kind of a pro combination, if you will. And when you think of those terms like that, it makes sense when you look at the definitions of retrospective or perspective. So your retrospective is payments that are based off of services that are received. This can be like a fee schedule that most providers will be following. We calculate all of the services after the patient has received them. And of course, there is a risk because you don't know how much you're actually going to need. And in many cases, a retrospective payment can increase the cost versus a prospective payment, which will tend to bundle it and make everything one solid payment. With the prospective, this is a payment where it's done ahead of time and you determine the need for the care based off of what's called an episode of care, or each time that the patient is seen for a specific type of service, type of inpatient encounter, or even at times over a period of time at multiple encounters for a certain type of care. Now, with the prospective payment, you determine what the cost should be based off of various data, either from the provider or from just the network area. But if the costs are more, then you end up losing money as the provider. And of course, if they're less, then you gain money. This is kind of a neat thing because providers do like to get more money, but it puts a risk on that because having a payment incentive based off of less services tends to be looked at negatively when it could potentially drive a provider to do payments or do services in a way that increases their payment. We'll look at risk on both of these, but we want to take a look at what exactly are these types. There's actually a lot of different types of methodologies for payment. And so we look first at our retrospective. Again, remember I used the word fee schedule. This is something that happens where each service is given a code. And as many of you have already taken ICD-10 PCS for procedural coding or CPT coding, you're probably familiar with how this is done. If you haven't done that or it's been a minute, it's just a reminder to let you know that every service that is done has a code associated with that. And in the US healthcare system, each code has a price that's determined by several factors, creating a fee schedule. Those fees can be, a fee schedule can be something that each provider group individually has, or something that the payer has, and oftentimes that both have. And in the case where a patient doesn't have insurance, they'll be on a self-pay fee schedule. In the case of an insurance payment, you'll see that there's a predetermined or allowable charge. And so what that just simply means is that the provider thinks they should be paid $150 for a service, and the insurance says that it's only worth $100. And if they contract, they have to reduce their rate to that. So contracting is really kind of the push for this. You'll hear terms like preferred provider network or in-network providers versus out-network. And it's what most people think of when they think of insurance. Another type of retrospective payment is a percentage of bill to charges. So instead of saying we'll pay certain charges and this is how much we pay, there are some plans out there that will pay just a solid percentage based off of the services. This is usually with more expensive services, like the example here with chemotherapy, or like unlisted services that aren't usually covered, where they just pay a set percentage of whatever you say it's worth. Again, when a provider is contracted, they do have to reduce their charge and accept that difference. So there's usually a write-off where it costs them $1,000 to provide it, but they only got paid $700. Sorry for the noise in the background. I have cats. Moving on. Our next type is per diem. Now, this is more of a facility type of payment. The first two that we looked at could be inpatient facility, inpatient provider, or outpatient services. And just a reminder of what those are. For every time a patient is seen in an ambulatory setting, it is considered outpatient. That's basically saying where the provider just bills you for the services and the hospital's not involved. There's not a lot of there's not need for a hospital room or nursing staff or various saline drips to hydrate your patient. That would all be included in a hospital stay or an inpatient setting. And sometimes even an outpatient facility setting, such as a surgical visit. Now, in the facility charges, when we talk about per diem, we're talking more like a patient goes to the ER, they're in ICU, so they're admitted, or they're in a regular hospital unit where they're admitted, or they went in for a specific surgical outpatient stay, and they may be admitted for the day or even up to 2 days, so long as it's no longer than 48 hours. In those kind of situations, regardless of the type of location, the per diem is determined based off of how their care is given. So in this example, they give us a fixed rate per day for a covered member in the hospital. And again, it's prevalent to the inpatient setting. It's not very common in an outpatient world, but this is a facility charge where they say, instead of charging for bedpans and tissues, we say, we gave them the room, which came with everything it needed, including any nursing staff and some basic services like a saline drip. And all of that's included in what's called an inpatient day. Now, this is per diem because it is per day. And even though it sounds like it's a prospective, meaning a payment up front for the service, we don't know how many days they're going to need. And so for that reason, it's still a retrospective payment, or more of a hybrid, if you will. Now we get into our prospective plans. The most common and popular is called a capitated plan or capitation. If reading these definitions where it says per member per month, that a patient is part of the insurance and they get seen for this defined period, they get to go to their doctor, and it kind of sounds like a membership, like a gym membership. If you're saying that, then you're on the right track because it's very much like that. Instead of a membership to a gym, it's more like a membership to your provider or a group of providers contracted with your insurance. Now, in this system, the payer will say, we'll give you X amount of money for each of the members that you have. And we'll give that to you every period that we have defined, which is usually a monthly period. This is really cool as a prospective payment system for groups that have a lot of patients who don't have acute ongoing illnesses. It covers for things like their physicals and their regular visits when they get sick, but it can end up getting really expensive to the provider if they have a lot of higher end services that they need paid. Another one that is very common, and this one goes again to our facility-based services, is our prospective case rate. Now, this one is it's a little challenging, and we will talk about it further on in our class, especially when we're talking about some of our projects later on this term. For now, the thing to know is that a case rate is basically saying that each time a patient is seen, they're considered a case or an episode of care, also interchangeable with the terms of encounter. So each encounter, each patient is a case. And when you're looking at a prospective payment system that is case rate based, they look at things in your hospital or facility where they say, what type of services does your facility tend to do? And they determine, based off of the data, how much it costs to treat each member that comes into your hospital or each case. That determination is then given a total sum. So let's say $1,000 per patient. It's probably more. And then each time a patient is encountered, they get $1,000 regardless of what they do with that patient. Now, this is where healthcare gets really confusing, because you've probably by now done some studies in some of your classes where you've learned about hospitals on one side of town charging double the cost for labs as hospitals on another side of town. A lot of this has to do with case rate, because they're looking at the types of patients you're receiving and how expensive those patients are. For example, if your hospital is a cardiovascular hospital and primarily deals with patients who have ongoing heart problems, which is a severe life-threatening condition in many cases, there's a lot of expensive testing that they have to do in order to treat that patient. But if you're more on a busy part of town, especially like say in like a college area where there's a lot of younger individuals who are seen mostly for things like acute illnesses or injuries that they can go see a regular doctor for, or they didn't have insurance, and maybe the area's not as well off. And so you have a lot of people who come into your hospital to get seen for things that generally are taken in a regular doctor setting. Then in those cases, each patient you see, you may have a lot more of them, but each patient you see ends up costing you less. You don't run the expensive tests that the cardiovascular hospital does across town. And so your case rate for that hospital that has the larger population who have less critical conditions will be a lot less in cost in order to provide services. And when you're in a prospective payment system, if you're the hospital with the cardiovascular systems, your reimbursement is higher than the hospital across town with the more acute conditions. All that being said, a case rate is determined by your area and the types of cases that you get. They determine the amount that each encounter should receive based off of the data, and then they give you that payment regardless of what happens. Okay, so we have two more to look at. Our next one is our global payments. So a global payment, you might think of something similar to like global surgery. If you remember from learning in CPT coding, we talked about this in a previous class where like every surgery includes, coming in to make sure they're okay for the surgery. If it's the same day, following up to make sure they don't have complications, but also the surgery itself, like making an incision, removing or repairing whatever you're removing or repairing, and of course, closing up any wounds that you create. That's considered a global charge. So in a similar way, a global payment also looks at just kind of everything they need for that visit. So the episode of care, which is usually determined by the diagnoses, will identify exactly what the patient is getting. If you're in a special unit, like a dialysis unit, you'll report the dialysis over a period of time, and you'll receive one lump payment for all of the dialysis that patient needs over that period of time for that episode of care. Another thing you might think of is a pregnant patient who comes into their midwife or OBGYN and receives several visits on a regular basis, sometimes more for certain conditions and sometimes less. They get a global payment in many cases for that. And that payment covers all of the services that that patient needs for that particular episode of care or condition and type of treatment. If the condition changes or the treatment dramatically changes outside of what's been approved, then you would submit for a different type of care and get an additional or different type of payment. Now, similar to that, we have our last one, which is a bundled payment. And this is just kind of saying all services required for a single predefined episode of care. So this is meant to include several providers rather than one type. So your OBGYN or your midwife for a pregnant patient may cover for just those office visits, but a bundled payment will also include things like urinalysis and laboratory results and x-rays if they need them, not to mention the birth and delivery of the baby. So all of that would be something that they might consider multiple providers that coordinate care together. This is mostly seen in like a big medical group, and it will be based off of the care itself. So looking at all of these together, as I mentioned, there are a couple of advantages, but there's also a few criticisms or disadvantages of each of these types. We probably talked a little bit about them already today, but just to kind of summarize on these, with retrospective, the biggest concern is that providers don't really have any incentive to do what's needed. At times, some providers may take advantage of that and just order whatever they feel like when it comes to ordering tests or procedures that maybe the patient might not always need. Sometimes it's not so much that the provider is trying to get more money, it's that they feel that this test may be worth more. But there's always this question of, could you have done it for cheaper in a different way? Then in your prospective payments, the biggest problem there is, well, I'm not getting paid anymore to do more, so why? And while that may not always be the case, it's certainly a concern when we're looking at this type of payment, because if we pay them the same regardless of what they do, there's less incentive to be as detailed in work and ensure that it is of the highest quality needed for that patient. And so we want to make sure that whatever we're paying our providers, that we're basing their care off of the needs of the patient and trying to drive medical necessity for services, not desire or preferential services. So one of the ways that we look to do that is through risk adjustment, or HCCs. I've mentioned this in previous classes where we talk about hierarchical condition categories. And these are primarily CMS, which is Medicare and Medicaid, although many private insurers use the same method. What is it? It's basically a series of diagnoses based off of common chronic conditions that need consistent management over a period of time. These can be things like diabetes, hyperlipidemia, BPH, various conditions that you'll come to be familiar, hypertension, as you're coding and as you see patients coming through your doctor's offices, or just as you're looking at anything of what is seen. These are the most common diagnoses that are seen for. That being said, many of them being chronic still need regular maintenance, even if they're perfectly fine. So we actually have a process in doing that. The process is HCCs, which gives a provider more payment for making sure that they're documenting appropriately to say that they're reviewing these conditions and what's going on with them, even if they're stable. This little graph here just kind of shows you how that's done, where patients come in each year, they document into the visit what was seen, including the health status. Now, status means what's going on with it, not just that they have it. And then they get additional payment because they did that. So with this, it really encourages providers to have good documentation. It encourages coders to be trained in identifying subcategories of conditions. So, saying a patient's diabetic is one thing, saying they're diabetic and currently have hyperglycemia or high blood sugar is important to identify and commonly missed. So, that's why we say well trained coders are ideal, but also new coders who have really learned those details or are detail orientated and want to focus on this area do really great in HCC coding. In our PowerPoint, we don't have figure 4.7, so let me pull that up for you here. Oh, I'm still here. So in figure 4.7, we give an example of a patient with good versus not so good documentation and how it defines an HCC. So this probably looks like gibberish the first time you looked at it, but it's all about risk adjustment, which means that the greater the risk to the patient who has these conditions, so the more conditions they have more risk. And then that equals more treatment, that equals more focus on them. And our providers should be identifying this not just for a payment, but also to say, what kind of risk does this patient present in getting severely ill? And a lot of data has gone into how they calculate that. The parts that we look at is these HCC scores. So each diagnosis, which is defined by a diagnosis code, is either listed as an HCC or not an HCC. And when they have this, it increases the risk of complication over time. In this first example, you have a patient who comes into the office with several conditions, and they mention it. They said past medical history, they had stable diabetes, arteriosclerosis, and BKA. But what they failed to mention is what the current status of those conditions are. And they focused only on the current problem they were seen for, which was BPH with LUTS. Now, in a yearly assessment, the first visit of the year or every 12 months, the provider should be taking a little extra time when they're an HCC provider, which is most of your primary docs. And they should be talking about those conditions that are found in the past medical history, mainly because there could be things that we miss that the patient doesn't know to tell us. And secondly, because some of those might be related to our current condition. A lot of times providers do this already. It's just a matter of putting it down on paper. So in the second example, they put it down on paper, like, yes, they mentioned previously stable diabetes. But in this example here, they didn't say previous. They said, well, yeah, they had type 2 diabetes. So they were more specific on the type. In stable BKA, they told us a little bit more detail about those, where the arteriosclerosis was. And then they told us the current plan. Like, what are they doing right now? Is it working? Do we have test results to support this? So all of this extra stuff here shows us, what are they doing? Is it working? And do we plan to continue? So they added this entire phrase here. We're just going to highlight it here. By looking at all of these things, we can identify different conditions the patient currently has, determine if they need to continue. And in this case, all they needed to do was continue the same conditions, but also identify areas where maybe they need to change or come in for a secondary visit to talk about those, since today they're clearly focused on the BPH. They still did the same plan for the BPH, but what changed here is our risk score. By identifying the things that the patient had, we determined, well, of course, they had conditions of the BPH, but they also have a diabetes, which has its own basic risk. There's a risk of patients who have diabetes of having complications at some point. And some others, well, these are very stable. They don't have any risk. But the BKA, which could come back and increase, has a risk score as well. And these point systems get added up. Again, those weights are determined by a lot of data and not something we need to focus on in this type of class. But what we do need to do is be able to say, what is the risk? And when it's a certain level, what other things do we need to do to treat them? And so that's what HCCs are based off of. That being said, risk adjustment coding is its own thing because it does have additional payments associated with your normal payment. And those scores do in fact relate to extra money for that visit because you did more in order to obtain those scores, but not just to obtain them, to treat them. And that's really what it's focused on is, are we doing the right things for our patient in order to kind of support that this patient is being taken care of the best that we can. The last part of our payment systems we look at are accountable care organization. And I'm going to pause the video as we get into this one, and we'll come back to it momentarily. Okay, so we're back. If you took a break, that's wonderful. We'll be done with this PowerPoint and talk a little bit about some of our processing next. So I'm going to go ahead and reshare the screen. And our next thing here is our accountable care organization. So here we go. So accountable care organization, this is kind of something I often like to refer to like Presbyterian, if you're in Albuquerque, New Mexico, or any other like large medical group. An accountable care organization is something that's identified by the payer, usually someone like Medicare or Medicaid, who are wanting to have a specific type of healthcare or through the organization. This is a model that will give payment to the entire organization for continuing on with their care, but it requires it to be a large enough group to actually give enough care to the patient. And so you're not thinking just one single type of provider, you're thinking of a whole organization that that provider is affiliated with. You have this really cool figure from your textbook here that really describes what that looks like on determining is a patient within the system eligible to be part of an accountable care organization system. So the beneficiary being the patient or the person benefiting from the health care. Do they have at least one primary care service furnished by the physician in the participating ACO? So the group is participating, so they've signed on a contract and they get a primary care doctor within that group and get some sort of services. And if the answer is yes, you continue and ask, was the greater portion of their primary care services furnished or received by the ACO's primary care clinicians, meaning it could be any of them, than by other ACOs or single TINs? So this is saying basically, to write this a little differently, was more like 51% or more of their services in a period of time, usually a year, that they received from a doctor from the same group, and or was 51% or more from other groups that weren't part of this group or individuals. So as long as more than 50% is given to them from this group, they are assigned to this as an ACO, and that's going to equate with additional payments for that provider's office. If not, or you have all these other scenarios, you won't assign them. The only other option is when they're talking specialists. It's the same question of primary care versus specialty care. So what does that look like? Well, we talk about next defining an ACO with Medicare. So Medicare Shared Savings Program is basically a program or an incentive that Medicare is currently running through, and they have a lot of them over the years. You'll learn about this now in class, but these will change over time. It's important to be familiar with how Medicare is doing their payments and what kind of additional programs your office may be able to qualify for, because that could indicate additional payments for your organization for services you already do, but may not get paid for it. There's two different types of risks. So your one-sided risk include having things that are less than expected, not required to share in the loss when it's greater than expected. So under a one-sided risk, it means one of the two parties takes all of the risk, not both. So that's what that's basically saying, is that share savings with Medicare, if Medicare makes savings, then you get to get savings as well. But if they take a loss, if they spend more money, it doesn't help you any. A two-sided risk is like two parties, and you have the ACO share savings with Medicare when they're less than expected. So same type of risk. Medicare shares their savings with you. But you also share in the loss when it's greater than expected. So basically saying, if you can save money and you're on this ACO, then you get bonuses for saving money on a one-sided risk. But if you lose money, if you spend more, that's okay. But if they identify you as a two-sided risk, which most advanced care organization models are, then you also take a loss when there's more expensive services. So they try to share that risk so that they can also share the responsibility. So patient connection. This is the part of the chapter where we really relate it to your patient. And we say, how does this work? So we looked at one patient earlier. This one wants us to take a look at a patient we saw in chapter 2 earlier in the term. Our patient, Olivia, is pregnant. Her insurance company, Superpayer, reimburses her OBGYN physician group, baby doctors, with a global payment methodology. So remember, a global payment means kind of like we were talking earlier, where everyone within the group, all the services related to that episode of care are included. Superpayer will reimburse baby doctors one amount for all the care provided during the period. And to see what that looks like, we have figure 4.5 to give us an example in our books. Let's actually look at our book real quick and go up to 4.5. So if we look at figure 4.5 here, you see that a global payment is basically where we take all of the pre, the post, and the during services. And this actually gives the surgical example I gave earlier. And it says the total charge for everything, but then it reimburses at a much lower rate to include all of that. The reason for that is sometimes those follow-up visits will be more and sometimes they will be less. And the idea is to treat the condition of the episode of care, not so much the specifics that are detailed into it. So it gives providers, sometimes they give them a little bit more freedom to do more treatment and whatnot. Excuse me. Here we have an example where we have the baby doctors charging for various visits over different periods of time throughout the entire pregnancy. And you can see during the beginning, there were more visits than during the middle and end for the second and third trimesters. But they had a total of 15 visits, and the charges on a fee for service would be $2,625. Then, of course, they did the delivery as well. And depending on the type of delivery, there's two different examples here. So obviously, Olivia is not going to be getting both vaginal and cesarean deliveries. It can only be one, although it can be one that changes to the other. And then after that, there's routine follow-up visits included in this entire global period of payment. And depending on the type of service, they give two different examples. The cesarean, of course, because she has an open wound, there may be additional complications, so it's a little higher of a reimbursement. At the end, they say, depending on the type of delivery, so at the very end, they're going to determine that. This will determine how she's reimbursed, either the 6,610 or the 8,970. And you can see both of these are actually less than the delivery itself. So it's definitely incentive for the insurance to do it this way. And it's certainly something that's a bit easier for patients who are self-pay to have a global period for those pregnancies. Our next example looks at Malachi, who went in to see Dr. Lewis, who is his primary care provider. We're looking at a traditional Medicare patient, and that means that we're going to be on a regular fee schedule reimbursement. So that means every service will have a reimbursement amount associated, which is a retrospective or prospective. You got it. It's a retrospective type of payment system. In this example, we have 5 levels of visits and what the traditional Medicare reimbursement amount is. And these are actually very close, if not exact, to the current Medicare reimbursement for most areas. Medicare does change how much they reimburse patients based off of the area. So different areas may see different amounts, especially like when you're comparing New York to, say, Wisconsin or here in New Mexico. We definitely have a difference in cost of living between the two areas. Now, the fee schedule amount is the total they receive, so that's here. In this example, they also have a 20% coinsurance or cost sharing amount. And so we have an example here where we look at a level 2 visit. That's a very basic visit, which is approved for the fee schedule amount of $46.19. To determine what Malachi will pay, we take the 20% coinsurance and we multiply it by the allowed amount or fee schedule amount of $46.19, thus getting a total of $9.24. Then Medicare will pay the difference of that, which can be calculated 2 ways, either subtracting $9.24 from the $46.19 or by multiplying the total fee amount by the 80% that's left. I highly recommend, as you're learning new math with this, it can come, it's basic algebra, but that can come as very difficult to some. So always try to calculate twice if there's 2 different methods and see if you get the answer the same both times. That's the end of our slideshow. So as you go on throughout this week, I want you to keep in mind some of the terms you've learned this week and take a look at how some of those different payment systems really apply to you as a prospective biller, coder, office manager, or anywhere else in the health informatics and health information management and technology field. If you have any questions, please feel free to let me know. Thank you for watching.